Hi everyone, welcome to another Monty Hart lecture series. And today we have Robert Miller, who will be speaking about applications of artificial intelligence in nuclear cardiology. Uh, if you don't know Robert Miller, I'm not sure what papers you've been reading in AI, but he's been very prolific, so it's a real honor to have him here today. Dr. Robert Miller is a clinical associate professor in the Department of Cardiac Sciences at the University of Calgary, and is the medical director of nuclear cardiology and cardiac CT program. He completed training in advanced heart failure and cardiac transplantation at Stanford University, and also advanced cardiac imaging at Cedars-Sinai Medical Center. His clinical work includes nuclear cardiology, cardiac CT, as well as time on the Advanced Heart Failure Service and Cardiac Function Clinic. This is a very interesting combination that I think gives him very unique skill set that we'll hear today in the lecture. His research interests include advanced cardiac imaging applications in patients with cardiomyopathies, as well as clinical translation of artificial intelligence. Thank you so much for joining us. It's a great pleasure to have you here today.
Yeah, thanks for the introduction. And thanks for the invitation to present. It's always nice to talk to a different group of people. Before I start, I do have some conflicts. None of these are directly relevant, although the grant from Alberta Innovates is sort of superficially related to some of the stuff I'll talk about today. In terms of our outline today, I'm going to try to go through things quickly here so we have some time for questions at the end, but I think it's always helpful to start with some terminology and basics, and then we'll just go through the typical workflow of a nuclear cardiology study, starting from like patient selection, a lot about reconstruction and segmentation, and then about disease diagnosis and risk prediction. Um, so whenever we're talking about artificial intelligence, it's just a catch-all term for any software algorithm that does something that we normally attribute to human intelligence. So it could be like image recognition, decision making, or like language recognition. For machine learning, a lot of it boils down to like a tree-based algorithm. So this is a lot like where you go and do this online test and you answer a series of questions and then it tells you your favorite movie. The difference is here, instead of a series of questions, it's like a series of factors, and then it tells you, do you have coronary disease or not? So the benefits of machine learning is it uses a lot of information. The trouble is you have to make sure it's good data, or else you end up with a bad prediction or a prediction that doesn't make sense. And the other thing is you have to make sure the training data is totally separate from the testing data, because if you had some mix between the data and you trained it for long enough, it could just learn to memorize the data set. There's also no preconceptions about what variables are important. This could be good because you might identify something that's novel and interesting, but sometimes you get a finding back and you're like, I don't know how this could make any clinical sense, and it takes a while to try to figure out why. And then interpretability becomes an important consideration because you want to be able to say, like, why is this prediction X for patient Y and it's different for a different patient? There's a lot of different methods for interpretability for machine learning now, so this is less of a barrier, but it's still an important consideration. And then if you're a total stats nerd, it's actually very good at handling interactions and nonlinear relationships, which is important because you can do this with traditional statistics as well, but it just takes more time and effort. When we talk about deep learning, it's referring this multi-layered learning approach. So with deep learning, it's really the structure of the model that tells you what it's going to do. So a convolutional neural network is frequently used for classification tasks. So when most people are talking about deep learning model, this is what they're referring to. Convolutional autoencoders and UNets are used a lot for image reconstruction tasks. So with a UNet, what it's doing is it's tasked with copying an image from the front, which is the blue, to the back, which is yellow. And because the layers are contracting in the middle, it forces the model just to pick out the most relevant features. And then it has these skip connections that allows it to feed back some details from the previous layer so that you end up with an image that's denoised but retains the image. So UNets are used quite frequently for image reconstruction tests. Deep learning has several benefits. It has direct image interpretation, so you can just feed it an image and ask it what it thinks. It can identify latent image features, which might be important. For instance, when we look at polar map perfusion tasks or perfusion prediction tasks, it ends up seeing a lot of subtle abnormalities on the motion polar maps. And then the last thing is it also has no preconceptions about what's important. This leads to an issue where it might highlight things that we know aren't clinically significant. So, for example, this was a deep learning model that was tasked with identifying COVID. And here it's integrating gradient class activation mapping to tell you what areas of the image are important for the prediction. And what you see here is it's identifying everything but the lungs for identifying COVID. So what it's looking at is actually these hospital-based X-ray tags. And then it's identifying if the patient is upright or supine. So it's essentially deciding, are they in ICU and what hospital were they at? And that's how it decided, did they have COVID, rather than looking at the lungs to look for COVID. When we talk about any AI, it's important that you understand how it was trained and tested. So there's different ways to do this. One way, if you just have one site for data, you might do something like cross-validation. This is where you randomly split the data into training and testing, and then cycle through the data until all of it's been used once for testing, but for separate from the training. If you have multiple sites, this is actually ideal because then you can do both internal testing as well as external testing. And that gives you a sense of how well the model would hold up if you used it in a new center. Couple other quick terms just to go through. Supervised learning is where AI knows the prediction task. So this is what we're most frequently using AI for, or what we're most used to seeing. So this is like a model that is trying to learn how to predict who has coronary disease, who doesn't have coronary disease. The other way that you can train a model is not to give it a classification task or an outcome that is trying to predict, but just ask the model to tell you something about the data or look at the inherent structure of the data. So this is referred to as unsupervised learning, where there's no specific task that is being directed to perform. You're just asking it, tell me more about the data. So why is nuclear cardiology a good case example for artificial intelligence? Well, I think the important thing is that there's many different touch points for a typical nuclear cardiology study. So it starts with patient selection, goes through image acquisition, registration, reconstruction, segmentation. And then at the end of the day, the physician wants to know, do they have coronary disease? What's the risk? And the cool thing about AI and nuclear cardiology is really could be applied to any of these tasks. So you can think about this all the way from patient selection through the end. So I think that's why it's just a good case example. Realistically, this is how it could be applied for any cardiac imaging technology. And really every aspect of cardiology could be thought of in just a patient workflow perspective. So I'm going to talk about image reconstruction first, and there's two reasons for that. The first is I think it's most applicable to our day-to-day process, and that's because most of us don't understand how the software is really reconstructing these images for us anyways. So it's very easy to integrate this into a workflow, and nobody cares if it's a traditional software doing it or if it's AI doing it. So actually, AI-based image reconstruction is further ahead in terms of clinical translation than a lot of the other things I'm going to talk about later today. Several groups have worked on image reconstruction, and in nuclear cardiology, a lot of our focus is on radiation dose reduction. So because we acquire a nuclear cardiology study over a series of minutes, what you can do is you can actually simulate lower dose images and then use AI to denoise and generate simulated high dose images. So this is one study that I thought was just particularly well done, where they simulated doses as low as 1/8 of the radiation dose, and then used AI to predict a full dose. So here they were using a generative adversarial network, which we'll talk about a little bit more, and the image denoising was a UNet generator. So here you can see the standard dose images are on the top row. the half dose, quarter dose, and 1/8 dose images are as you go down the rows. And what you can see is as you get to lower radiation doses, the images are getting noisier. You start to have larger perfusion defects than what you would expect just from attenuation. As you go through the predicted full dose images with AI, you can see that most of these look pretty similar to the standard dose images, except for the predicted images from 1/8 dose, where they just look over smoothed. You can then look at this a bit more quantitatively. This is looking at the correlation between the actual full dose images, the predicted, and the low dose images. And you can see that AI was more similar to the actual full dose images, really regardless of what dose was simulated. Another major issue in nuclear cardiology is attenuation defects. So this is actually the bane of most of the cardiology fellows that rotate through the nuclear cardiology elective, is trying to decide what's real and what's fake. So one way to address this is CT can be used to correct for these attenuation deficits. Most scanners used in the US and Canada are actually not hybrid systems, so CT-based attenuation is not available. This is another task that maybe deep learning could be doing for us. So this is work we did again with a generative adversarial network. So the idea behind a GAN is that you have two models that are trained in parallel. So here the generator is a modified UNet, and it's creating simulated AC images, or deep AC or synthetic AC. And then there's a second model that's tasked with differentiating the synthetic attenuation correction from the actual attenuation correction. And its task is just to say, this is fake, this is real. And then what you do is you train the models in parallel until the generator is able to fool the discriminator. And by that way, you end up with images that are more similar to the actual images than if you just use a UNet alone. So these are case examples from this study. So what you can see here is NC is non-attenuation corrected, AC is the CT-based attenuation correction, and deep AC is the synthetic AC images. On the NC images, you see that there's a defect in the inferior wall that's relatively mild at the base, consistent with diaphragmatic attenuation. If you look at the AC and the deep AC images, you can see that they look very similar. Quantitatively, there was a 11% stress total perfusion defect in the NC images, which was normal in both AC and NC. On the right, you can see a quantitative measure to look at differences between images. That's called a change analysis. And what you can see is that there's more dissimilarity between AC and NC than there is between AC and deep AC. What you want to make sure is that it's not just smoothing over all the defects. So this is a case where there's a defect in the circ territory. And what you can see is that that defect is really preserved with both CT-based attenuation and deep learning-based attenuation correction. And just one more example of a normal study here having a defect at the base, which again is probably a variant of a diaphragmatic artifact that resolves with both CT-based AC and deep AC. This is looking at that quantitative difference between images. What this shows is that the AC and deep AC images were more similar than AC compared to NC images, or deep AC compared to NC images. And then really important is always like, how well does it predict coronary disease? Here you can see that deep AC was just as accurate for predicting obstructive coronary disease as actual AC, and both of these beat out non-attenuation corrected TPD. Segmentation is a task that's becoming increasingly important in nuclear cardiology, less so about the nuclear images, because this is something that software has gotten very good at over time, but more so with the CT images that are used for hybrid imaging. So this is work from my center where we just looked at expert visual interpretation of CTAC images and just giving people 4 categories, either no coronary calcium, equivocal, present, or extensive. And in this paper, we showed that just that 4 group categorization was very useful in stratifying risk of MACE. The trouble with CT-based or hybrid CT is that they're required at very low radiation dose, so the image quality is very poor. And it's a limited number of slices, so it's not exactly the same as a coronary calcium score. That being said, it is possible to try to derive a coronary calcium score from these CT attenuation images. So this is a study where we used a convolutional long short-term memory model. So the general idea for this model is you're trying to provide the AI model with context. So you show it both the slice that it's seeing as well as the slice above and below. So it's sort of mimicking the way that we look at most of our CT images, whereas if you see something you're not sure what it is, you sort of scroll up and down to try to get context. So this is providing the same thing for the AI model. And what it does is it first extracts where it thinks the heart is, and then within that mask, it extracts the portions of calcium that would be either in a coronary, which is in red, or non-coronary structure, which is in green. So for this paper, there were 6,000 patients that were used in the training population and then external testing in a separate population. They were scored both by an expert interpreter as well as a deep learning model. So yes, some poor person did have to score 9,000 something CTAC scans for a calcium score, and then a deep learning model did it in 1 second per case. These are just examples from the study. So the first case, you can see that there's some calcium in the aorta, calcium in left circumflex artery, and both the AI and the expert interpreter scored the same segments. Like I said, these are really noisy images, so there's some pixels that you might confuse as calcium just because of the image quality. Here, deep learning score was 0 as well as expert score was 0. And just one more case at the bottom, whereas a location that could be quite difficult for some interpreters, which is calcium that's mitral annular calcification. So here you can see that the RCA is marked in red, and this calcium that's in a mitral annulus is green by both expert score and deep learning score. So the scores aren't totally perfect. And honestly, if you have two readers score all of these cases, they would also not be totally in agreement. But overall, the agreement was quite good with a Cohen's kappa of 0.8. But outside of just the classification, the real question is how well does this predict risk? So this is looking at risk of MACE by those categories of coronary artery calcium, either by deep learning or expert reader. And what you can see is that there's similar risk stratification across the categories. And if you look at the hazard ratio between these different categories, you can see it's very similar between deep learning and expert reader. The biggest difference is the time it takes. So deep learning takes less than 1 second. Expert reader, 5 to 10 minutes, depending on how long you're going to spend on it. On the right is just the visually estimated calcium scores that I showed you before. They don't quite provide the same risk reclassification as you get from a total score. So maybe there's some benefit of just running this deep learning thing in the background and getting a score of your CTACs. We have looked at the same idea, looking at PETS studies. Here, the interesting thing was we had paired expert reader ECG-gated CT scans as well as deep learning CTAC. And what you can see is that the risk stratification from calcium score off a CTAC ended up being very similar to proper ECG-gated dedicated cardiac CT for calcium score. So providing very good information from these low quality images. So all of this work was really encouraging for us. So we started thinking about what other things that we could segment from hybrid imaging. So Dominique Day's group has done a ton of work in epicardial adipose tissue. So this is work that was led by Evan Eisenberg, but looking at a deep learning model for epicardial adipose tissue segmentation off of a gated cardiac CT scan done for a calcium score. And what you can see here is that there's excellent agreement between expert reader and automated EAT measurements. R was 0.905. And these values provide incremental benefit over the calcium score. So you can combine just these two features to really stratify risk quite effectively. We wanted to see, could we use the same approach again with these low quality CT attenuation scans? It's really problematic, at least in theory, for epicardial adipose tissue because you're looking for a density-based measurement adjacent to a structure that's moving, so it could significantly complicate the task of segmenting it. So what we did here is we split the data into internal testing, 3,500 patients, external testing, 3 sites with almost 5,000 patients. And we use the same setup as for the calcium score model. So what it does is, again, it's this convolutional long short-term memory model. And then we use the heart mask to extract where the pericardial space is, and then use the segmentation based on density to get the EAT. And at the same time, we could get the calcium scores. So here, expert reader segmentation of EAT takes 15 to 30 minutes, depending on how complex it is. So here, some poor person had to segment out 600 cases, which you can imagine was a significant amount of effort. And what you can see is that there's very good correlation between EAT volume and EAT attenuation, both in internal and external testing, when you compare the deep learning model to the expert reader. These are just a couple of cases as examples. So on the top case, you can see a 51-year-old male, calcium scores 1,000. His EAT volume is quite high at 179 mils. The EAT density was also above our threshold. So the idea is that if you have underlying inflammation, especially around the coronaries, that can increase the attenuation of fat just because there is like some surrounding inflammatory changes, and that changes the median attenuation of EAT. So this patient experienced an MI at 207 days. Second patient, very similar calcium score, somewhat similar BMI, but this patient has very little EAT, and the EAT is lower density. This patient had no events after 3 years. Here we looked at the additive risk between EAT volumes as well as perfusion, and you can see that they provide some incremental benefits. So patients with low EAT, normal perfusion are the lowest risk. Patients with high EAT, abnormal perfusion are the highest risk, and everybody else is in between with really a risk that seems comparable. We went on to do more significant adjustment, and I'm just going to blow this up just because it's difficult to see without that. And what we saw here is that both EAT attenuation and EAT volume were significant independent predictors of death or MI in both the internal and external testing populations. So EAT is just one portion of body composition that could be segmented from CTs. There's a lot of other things that could be of interest. So this is work that's utilizing a NN-UNet, which is similar to what Total Segmentator is. It was modified somewhat to get these results. But what this model does is it's segmenting out first from the CTAC. It automatically restricts the CT to the area between T5 and T11. And then within that volume, it segments out the subcutaneous fat, the visceral fat, intermuscular fat, bone, and skeletal muscle. And then we use the same model we used before for EAT volumes as well as calcium scores. And then we looked at the risk associated with these measurements. I can't share all the results because some of them are under embargo, but this work was just recently accepted in Lancet Digital Health, so you'll be able to see more of it once that comes online. These are just a couple case examples of the segmentation. So here you can see subcutaneous fat in light blue, epicardial fat in dark blue, visceral fat in black, or in green, sorry. So the interesting thing that came out of this study is that subcutaneous fat in general, the higher the volume, the lower your risk. Whereas visceral fat, the higher the volume, the higher your risk. So the simple way to think about that is not all fat is created equal. The other way to think about it is like we are supposed to put fat in subcutaneous space. We're not supposed to put fat in visceral space. So fat that's where it belongs is probably good for you. Fat that isn't where it belongs is bad for you. Again, as these papers come online, a lot of this information I could share a bit more, but I think it's an emerging area that's really interesting. The other things that are interesting to come out of this are skeletal muscle volumes and density are quite important, as well as bone volume and density. Like I said, a lot of this was built off of the network that was created for Total Segmentator. I want to talk about this a little bit because it was trained in a really interesting way. So it started by being trained off a small subset of CT scans where somebody went in and manually segmented all of these structures top to bottom. So it probably took hours and hours and hours to segment all these things. Then what they did is they trained an early version of the model and had the model pre-segment the next set of CT scans that were refined. And then they iterated this process until they had a model that worked pretty well. The interesting thing about this model was it was trained on both gated contrast enhanced studies as well as non-contrast studies. So you could apply it to extract cardiac chamber volumes from gated contrast enhanced CT, but it can also estimate them from non-contrast studies. So we went on to apply this approach to hybrid images acquired for SPECT CT. So again, these are these low radiation dose, really poor image quality CTX studies. And what we did is we estimate RA volume, RV volume, LA volume, and LV volume, and LV mass. So if you just think about a typical perfusion study, you're only going to get LV mass and LV volume. And there's limitations to this. So the limitation is shown on the bottom right here. So if a wall is missing, it's really hard for a software to find it with just nuclear alone. Whereas with CT, you can always estimate the wall as long as there's no issues with the CT images. But you also get left atrial volume, which ended up being quite important in a lot of our predictions and models. As part of this study, we did look at a set of patients with paired scans. So these were a cohort of patients with both gated contrast enhanced scans as well as ungated non-contrast scans. And we compared the cardiac chamber measurements from these two sources. What you can see is that there was great agreement for left atrium as well as for right atrium and right ventricle. LV myocardium, there was good correlation, but a tendency for the gated minus ungated, sorry, it was a tendency for the ungated measurements to be larger. And then similarly, if you look at the left ventricle, there was a tendency for a difference between the measurements. I think this is expected because when you get a CTAC, you really don't know what phase you're getting. Whereas when you do gated contrast enhanced studies, typically you're getting end diastolic, where these measurements are going to be larger. We went on to look at both unadjusted and adjusted risk. Like I said, left atrial volumes tended to come out as very important, especially in adjusted analyses. So it was great to see that there was good correlation between the ungated non-contrast studies and the gated contrast enhanced studies. Other things like left ventricular volume, RA volume, RV volume were all important, but weren't quite as important in adjusted analyses. We've gone on to look at the same thing in PET scans, and the interesting thing is here they actually are better at predicting heart failure. So if you look at the number of chambers with abnormal volume, you can see that patients with 3 or 4 abnormal chamber volumes had a 7-fold increased risk of heart failure hospitalization compared to patients with normal volumes. And I think this is something as cardiologists we say, well, yeah, we already know that. But the big difference here is that these could be automatically derived during your perfusion scan to provide incremental benefit. So I'm not sure about your lab, but at my lab, I get a lot of referrals for dyspnea. Like people think maybe it's anginal equivalent. So this is a way that you could provide the referring physician with additional information that would say, hey, maybe you should think about heart failure just because his left atrial volume is high or his LA and his RA volumes are quite high. So it's information that's there. It's freely available, could be given, we're just not using it. As you mentioned, I'm a heart failure cardiologist, so I like to think about a lot of cardiomyopathies when I'm doing this as well. So this is image from a pyrophosphate scan. As we all know, the planar images aren't great, and we've really shifted to using SPECT and SPECT CT images. So what you can see on the left is a patient with ATTR cardiomyopathy, and what we see on pyrophosphate is that there's diffuse myocardial uptake. And in patients without ATTR cardiomyopathy, we see really only blood pool activity. We did work on a method to quantify this activity. In this case, study, I was the poor sucker who was drawing the circles. So I would draw one region of interest in either the left atrium or the left ventricle to get a background, and then I draw a region of interest over the left ventricle. And then you can quantify all of the abnormal activity, which we just said is anything that was a certain threshold above background. Here, VOI is the volume of abnormal activity. CPA is a method that combines both the volume and intensity. And these are quite predictive of ATTR cardiomyopathy, which truthfully isn't a very difficult task with SPECT interpretation. So SPECT interpretation performs just as well as these quantitative methods. But what we wanted to do after this was not draw any more circles because I had drawn enough at this point. So we wanted to see if AI could draw the circles for me. So here we use that same method for extracting the cardiac chambers and then modified them to use them as a sampling tool. So for the left atrium, we looked at a full-size left atrium shrunk volume as well as random sampling within the left atrium. We also looked at right atrium and aorta backgrounds. And then we used the LV myocardium segmentation as the target. So this is just a case example of how this works. So again, these were these low dose, poor image quality CT attenuation scans, but you can still estimate the cardiac chambers. And from those, you can then segment. So this is a patient with ATTR. You can see that they have diffuse myocardial uptake. You can see that the myocardial segmentation covers most of the abnormal activity. And you can see that both the volume of involvement and cardiac pyrophosphate activity are elevated. The nice thing about these metrics are the cutoff is 0, so anything above 0 is abnormal. Here it's a case of a patient with just blood pool activity. You can see that the region of interest actually nicely fits right around where the blood pool is. And this patient had no ATTR. We went on to look at prognostic value of these measurements, which I think is probably a more important task. And here you can see that all of these automated measurements that, again, could be automatically provided with any pyrophosphate scan were associated with an increased risk of either cardiovascular death or heart failure hospitalization, with about a 50% increase in risk per standard deviation increase in metric. We are working on applying the same process to sarcoid studies, which are potentially more problematic to segment automatically. And that's just because with sarcoid, you get a bit patchier uptake. So software systems are able to reliably find more continuous uptake that you can see in ATTR cardiomyopathy sometimes. But with sarcoid, you have this patchy activity that could be difficult to segment automatically. Here we can see that volume of involvement, or sorry, volume of inflammation and cardiometabolic activity were abnormal in this patient with sarcoid. This is a patient without sarcoid. And again, you can see that these segmentations sort of help with finding where myocardium would be on the hybrid images. So that was a ton about segmentation. Hopefully you're not sick of seeing circles. Now I'm going to move on to some disease diagnosis and risk prediction. So this study, I'm going to gloss over mostly just for time, but this was a study that we used to select patients with abnormal perfusion based on pretest features. Whenever we're evaluating an AI model for tasks like obstructive coronary disease prediction, it's important to see does the predicted risk actually fit the actual risk? So this is really just a slide to highlight the importance of external testing. So when you train the model with one set of data that has a certain prevalence of abnormal perfusion, that becomes like the baseline risk for the machine learning model. So then if you apply it in a new population that has a different risk, here there was more abnormal perfusion, you can see that the predicted prevalence is systematically underestimated externally. So just an important clue that external validation is important for all of these models. Whenever we have machine learning, we can generate these feature importance plots. So this is based off of information gain. Here you can see that the things that we would expect to be associated with abnormal perfusion, prior coronary disease, past MI, are right at the top, which is reassuring. Whereas other things like left bundle defect takes a little bit more thought. But obviously left bundle can cause left bundle defects, and maybe that's why it's associated with abnormal perfusion. We can also apply the same process to help select patients for stress-only testing. So if you're doing stress rest protocols, you need to at some point decide whose rest scan can be canceled. A lot of labs try to do this by reviewing all the images in real time to decide by a physician. Another way to do this is just to automatically extract all the features, have a machine learning model select out who needs a rest scan and who doesn't. This is kind of nice as a case for AI because it's a low risk proposition. If you disagree with the AI, maybe they got a stress scan they didn't need, but it's still going to decrease the total, sorry, rest scan they don't need. It's still going to decrease the total number of rest scans. And if you disagree with machine learning and say, well, I need the rest images, you can always bring them back the next day. It's not like it's a high risk proposition. So here, the machine learning model significantly outpredicted total perfusion deficit, which is a quantitative method to look at perfusion or reader interpretation of the studies in terms of finding patients with obstructive coronary disease. It's also better for finding patients at risk of MACE. The trouble with this machine learning model is it has a ton of variables. And you're not intended to be able to read the slide, but it's just to highlight there were a lot of variables. So our next work looked at ways to decrease the number of variables. So first we started by saying what variables can you extract from the DICOM header? So that's free information that could be fed into the machine learning model without any additional work. And then what do you actually have to extract? So some things you have to go to the stress test and say, well, what's the stress peak heart rate? Do they have these comorbidities? So we labeled all of these as manually input features. And then what we did is we developed a machine learning model that just had the image features. And then we added manual features until the prediction performance plateaus. And then at that plateau is where you say, well, that's the total number of features you need. So with this, you could use just the first several features and exclude the vast majority of manually input features and get a risk prediction that was almost the same as this full model that had almost 70 features. Moving on to something just a little bit different. This is our explainable deep learning work. So this was led by Yuka Otaki as well as Ananya Singh. So here it's a deep learning model that is sort of modified CNN architecture. The interesting thing about this model is it incorporates gradient weighted class activation mapping. So the idea of this is that it helps you look backwards through the model to highlight the sections of the image that are contributing to the risk. So here the inputs are polar maps, just because it's an easy way to look at perfusion in 2D. And then age, sex, and volumes are incorporated in the last layer of the model. And then the output is not just the probability of coronary disease, but these explainability metrics. So the first is an attention map. This is the easiest to understand. Here it's just gradient or GradCam is highlighting the areas of polar map contributing to a prediction of coronary disease. So if it thinks they have coronary disease, it highlights the area of the polar map that's driving that prediction. It also gives you per vessel probability as well as a attention map that just highlights the segments that are contributing most. So this is a case example. So here what you can see is that there's a small defect at the apex. This is something that could be related to apical thinning, could be a distal LED perfusion deficit. Here, the model says that it's a higher risk of coronary disease, 75% probability of LAD disease. It's highlighting the same area of the polar map as well as the segments that you'd expect. This patient obviously had LAD disease, or else I wouldn't show it to you. This is the result for the overall population. And what you can see here is that the deep learning model outperformed total perfusion deficit as well as expert reader interpretation. We also did external testing for this where the deep learning model outperformed TPD. So just two more cases just to highlight how this works. So here you can see that stress and rest perfusion, you can see that there's a partially reversible defect primarily in the inferior wall that's moderate intensity, moderate in volume. And the deep learning model is saying that there's a high probability of coronary disease. It's highlighting the same areas of the polar map, but interestingly, it extends out to the apex. And actually, if you go back and look at the images and the polar maps, you'd say, well, yeah, it's extending more into the apex than I would have expected just with an RCA lesion alone. So it's actually calling a high probability of LAD and RCA disease. So maybe a way that you could pick up multi-vessel disease that otherwise may have been blown over just by reviewing the images. This patient did have LAD and RCA disease. There was an 80% distal RCA and 70% mid-LAD lesion. This is another case here. What you see is that there's a partially reversible defect, primarily in the septum, anteroseptal, infraseptal segments. But the deep learning model says there's a low risk of coronary disease. So this is one that you might have called abnormal. The deep learning says it's low risk. You could go back and review the images and say, oh, well, they had a left bundle and they were exercised for some reason. So it's probably just left bundle defect, and you could downplay it a bit. So as you can tell, a lot of that was designed to help physicians read better in conjunction with deep learning. So we followed that up with this study where we had 3 readers to read 240 cases the way we'd read any other case. So they got the clinical data, the stress results, the perfusion images, and they scored them all. They then did the exact same thing, but with these explainable deep learning predictions, just to measure the incremental benefit from those explainability parameters. So this is the top line result from the study. What you can see is that the readers with deep learning beat readers without deep learning. As you can tell, they're already quite good readers because they're outperforming stress TPD, which tends to perform better than readers in most studies. You can look at each reader independently, and what you can see here is that each reader improves a little bit upon themselves with deep learning, some more than others. One of the readers improved significantly, whereas another reader had less important or less significant improvements. The other interesting thing about this study is it gets into this psychology of the interaction between AI and humans, because you could look at these results and try to interpret what people are doing. So if you look at this first reader, there's improvements in both sensitivity and specificity. So I think about this person as the AI believer. The second person, there is an increase in specificity, but no change in sensitivity. So it seems like how this person is using AI is if they think there's coronary disease, they're calling it. If they're on the fence and they say, well, maybe it's equivocal, if AI is telling them it's low risk, then they'll call it low risk. So I call this person the AI rule out person. The third person, there's improvements in sensitivity and specificity, but not all that great. I call them the cautious skeptic. And then if you look overall, there's generally an improvement in both sensitivity and specificity, but again, each reader is a little bit different. We went on to try to modify this to make it work better for readers. So a lot of people are used to just the sum stress scores that come up automatically with software. So this study, what it did is it used the GradCam predictions and the per vessel probabilities to modify software scores incrementally. So if deep learning said that there was a low risk of coronary disease in a coronary distribution, it would sequentially decrease the TPD scores until it reached a certain threshold. Similarly, if it thought there was a high risk of coronary disease, it would sequentially increase the scores until it hit a certain threshold. So it's a way of using the deep learning predictions to derive scores, but also keeping it within the confines of what software would typically be able to do. I'm going to skip over the case just to do a couple other studies, but the interesting thing from this study is actually the deep learning scores, because they're incorporating both the deep learning model as well as like traditional software parameters, actually outperformed the deep learning model by itself, which we were a bit surprised by when we ran the study. But it's probably because it's benefiting from the traditional software-based knowledge of perfusion. You can use these same models to predict risk of death or MI. And again, with quite good risk prediction and improving upon either stress TPD or ischemic TPD. So two last things quickly. So a lot of what I've been talking about was supervised learning. So again, supervised learning is like asking the model which of these candies is going to be delicious. This other way you could do this is ask the model to tell you something about the candies, like sort them by the groups that you think are important. So here it would probably sort by color, just because that's the biggest difference between groups. Um, you can ask it to do the same thing. Here we were asking it to look at SPECT MPI patients, and we had both training and external testing population. And what you can see is that our final model had 4 clusters as the optimal difference. Um, you can see that they're quite different in the training population, but there's a bit more scatter in the testing population, just because it's not the population it was trained on. But what you see is that does provide incremental risk prediction. So this was primarily splitting patients based on mode of stress, just because mode of stress drives a lot of things. It drives what's your stress heart rate, what's the stress blood pressure. But the other things it looked at were LV function, TPD, and age is what seemed to be important in the classification. And then last but not least, I thought we should at least talk about large language models just because they're so popular in the lay press. So if you just ask ChatGPT, how should I use large language models to help me improve clinical care? These are the categories. It has actually a rationale for each of these. Some of these rationales are reasonable and some are not. These are the considerations for use that it would come up with. One thing that comes up a lot in academic literature is like, how well do these perform on board exams? Valerie Buloff led this study looking at the ability of these models to pass the ASNC board prep exam, which is very similar to CBNC exam. Um, what you can see is that the overall performance of these models was not great. And if you look at the median accuracy, they're sort of in the 60% range, which is right on the cusp for what we think would be a pass. So certainly some work to go. There's also some work that she's currently working on where you feed it with specific context before. So you give it a bunch of prompts with ASNC textbook information. And what she saw is that the accuracy improved to the 70% range. So still not great, but better. The important thing about these models is they're developing so fast that realistically, this is something that is going to work better 5 years from now. So in terms of how we incorporate that, we can always talk about that on the question period, because I think a lot of people have questions about that. But just to leave enough time for questions, I think we'll stop there.
Thank you very much, Robert. That's amazing work you've been doing and very, very prolific. And we were chatting before about, your fellowship at Cedars and how much you've done. And so congratulations on that. And so please put the questions in the Q&A. We'll go through them. And we have first a question from Mark Travin. You talked about how important it is to have these validation databases, that the probably should be diverse, large. He asks, is there AI work combining AI NUC findings with individual patient characteristics such as ethnicity or genetic profiles to improve diagnostic accuracy and better predict outcome and guide management as a way of personalized nuclear cardiology?
Yeah, I think that's a great question. And I'm going to break it into 2 parts because, like, I think there's a embedded question there, which is like in terms of the diversity side of our AI models. So what I'll say is if you just train an AI model in a unselected cohort of patients, let's say for finding coronary disease, and you select patients who all went for cath, there's huge bias in that cohort. So we did a study where we looked at prediction performance in men versus women in that training strategy. And what we saw was that it worked really well for men because the population was mostly male. And it didn't work as well, especially for calibration in female patients. And that's because it's a high risk cohort. So what we ended up doing was training 3 models where we added more and more normals to try to get the calibration improved for female patients. And then we increased the proportion of females that were reflected in the training population. So this was for a deep learning model. And by doing that, we could improve the prediction performance for female patients. But the trouble is, there's a lot of patient populations that would be underrepresented. So if I just looked in Calgary, we would have a high number of Caucasian patients and we would be underrepresented for every other racial minority group. So I think this is an important consideration, especially once you start talking about implementing it clinically, is you want to make sure that the predictions aren't going to have unintended consequences for minority groups. The best way to get this data and to train models that are unbiased, I think is still a moving target. So the second part is like, is there ways to incorporate a lot of patient features into diagnosis and risk prediction and guiding management? Yeah, it's all about, and it's a very important question. It's all about the data that you have on these patients and the quality. So if you had high quality data in terms of racial and ethnic diversity, it could be incorporated and help improve predictions. Other things like medical history, we're really used to incorporating. And because machine learning and deep learning can handle these interactions and nonlinear associations, you can sort of pick out what's important for each of these subgroups. But I think it's still an important area on the diversity and DEI side. Um, it's in terms of guiding management, it's like a two-headed problem. Because like if you just look at nuclear cardiology for selecting people for revasc, it's a really complicated statistical question because you have to account for bias driving revasc. So you can do the same thing with AI, and we're working on a paper for this, but it's like you have to do all of the AI side and deal with all the propensity side. So it's actually like three papers in one to do it properly.
That's a great answer. When you're evaluating these models, I guess my question is, what should be the gold standard as one part, and the other side is how much is good enough, or how much value do they need to add to an AUC, or in order to be creating value actually. What are your thoughts on that?
Yeah, I think that's an important consideration. So, in terms of improvement in AUC, I usually peg it around CTAC, whereas like a lot of the data for like AC improving accuracy would say it's like a 3 to 5% improvement in AUC. So you'd want to see something that could be implemented without impairing workflow that provides a 3 to 5% benefit in AUC, I think, for it to be useful. Value is like a loaded metric because value incorporates like how much do you pay for this. And obviously, like this is a big issue for CT, right? It's like you can do a lot of things like deep learning plaque and FFR CT with machine learning, but like how does it get reimbursed? What's the value to the patient? What's the cost to the patient? So that's a really interesting point of discussion, I think. What was the first question?
What should be the gold standard? Should
Oh,
be an expert's reader? Should be outcomes?
it's really tough. I think it depends. And the real trouble is like oftentimes there's no perfect gold standard. So like amyloid, it used to be the gold standard with biopsy, but now not a lot of patients get biopsy. So now we're using like imaging as the gold standard for imaging, which is a circular definition and inherently flawed. For coronary disease, like I think we could debate if it's important, if it's anatomic or functionally significant. The reality is there's not a lot of patients prospectively going for invasive FFR measurements to be a gold standard. So I think it depends on the exact question. I think expert reader is a really difficult gold standard because at most you're training deep learning to be as good as readers, which we know are imperfect.
Yeah, 100%. The question is, I guess, if you don't use readers, then you're only using like randomized clinical trials because they're the only ones that can be
Yeah.
big enough. And then do they apply to real world? So
Yeah.
you think
I
there's
mean,
still value of real world data here?
I think so. I was about to say, well, the only one outcome nobody disagrees with is death. Like people were either alive or dead at the end of the day, so death is a pretty good gold standard. But yeah, expert reader versus anatomic versus functional measurements for disease diagnosis is um, always tough, I think. Yeah.
Thank you
And
very
then
much.
there was one other good question in the chat, which
From
is,
Danielle, yeah.
have you tested it for detecting left main disease, which is like the classic Achilles heel? So in that work by Evan Eisenberg, she did look specifically at just left main disease, and it does help you identify left main disease, but realistically, SPECT isn't going to catch all balanced ischemia. Like there's inherent flaws to the technique. AI can't get rid of some of these inherent flaws. Um, in some of the deep learning studies, when we were looking for case studies, just to include, one has like increased RV uptake, and that was the only sign of left main disease. So it was missed by the expert reader. It would have been missed by me if I was reading it in a stack, but it was picked up by AI and it ended up being balanced three vessel disease. And in retrospect, it had increased RV uptake. So maybe it won't be perfect, but it might help you clue into some of these other traditional findings that we are always looking for, but sometimes gloss over.
Thank you. Yeah, that's very important. Well, thank you very much. This was wonderful, and we're right on time. And we'll keep reading your papers, and congratulations again. And we look forward to receiving you here in New York if you're around.
Yeah. Thanks again for the invite. Have a good rest of the day.
You too. Bye bye.